I'm Dr. Stephen Roman. Today's webinar will be on steroids in your joints. References will be provided at the end in the order of the material presented. Questions I will answer in this webinar include: what are steroids and what do they do? Why are steroids used in orthopedics and spine care? What evidence do we have for steroids in arthritis? What evidence do we have for steroids in tendon pathology? What about local anesthetics, which are usually injected along with steroids? How do steroids affect the rest of the body? Why are doctors still using so much steroids? And what are some alternatives to steroids? Let's begin with, what are steroids and what do they do? When we refer to steroids in the treatment of orthopedic and spine care, we're referring to a type of hormones called glucocorticoids. These are a type of hormone that's naturally produced by the body, mostly in the adrenal glands, and are based on our own body's main glucocorticoid, which is cortisol. Cortisol is essential for life and is important in regulating the body's functions in the immune, metabolic, and cardiovascular systems. And it's important in homeostasis, in other words, helping to keep the body's systems working together in harmony. This is not the type of steroids that bodybuilders use. They use anabolic steroids or building up steroids. Glucocorticoids are catabolic or breaking down types of steroids. Some of the steroids used for injection in musculoskeletal conditions include methylprednisolone, betamethasone, dexamethasone, and triamcinolone. The discovery and use of glucocorticoids is known historically to be one of the most important breakthroughs in medicine. They have saved many lives and continue to be effectively used today for various medical conditions. Glucocorticoids are used to replace the body's natural cortisol when there is insufficiency of the adrenal glands, leading to low cortisol levels, such as in Addison's disease. Glucocorticoids can also be used to treat conditions where it's desirable to decrease inflammation, such as in asthma, autoimmune diseases, as well as in some infections and cancers. Steroid injections have been used in the treatment of orthopedic and spinal conditions since the 1950s. They work by targeting gene transcription related to inflammatory proteins and cytokines, or cellular messengers. So what evidence do we have for steroids in arthritis? A summary of studies on steroids for osteoarthritis demonstrated that in the clinical setting, intra-articular steroid injections for arthritis of the knee provide temporary benefit, with most studies reporting 2 weeks, with perhaps modest benefit remaining at 8 weeks. Steroids have been shown to have possible helpful effects in arthritis in animal studies. However, this is in low doses, much lower than the doses usually given to people in clinical practice. On the other hand, laboratory studies and animal studies with microscopic and biochemical analysis have shown detrimental effects of steroid injections on cartilage. The effect of steroid injections in arthritis remains a controversial topic. Steroids, although providing temporary pain improvement in arthritic hips, are showing negative effects in the long term. Clinical studies, including one recently funded by the National Institutes of Health, have shown that steroid injections in the knees actually decrease cartilage thickness and speed up the progression of arthritis. And finally, a recent observational study of over 3,000 patients found that patients who received steroid injections for knee arthritis were more likely to need a knee replacement. What about steroids for tendon pathology? Steroids work primarily by their anti-inflammatory characteristics. This is why they're so effective in autoimmune disorders, such as rheumatoid arthritis and lupus. Most tendon pathology we encounter is not an inflammatory problem, rather a degenerative problem. So it doesn't make sense to try to treat a non-inflammatory condition with an anti-inflammatory. The correct term for most clinical cases of tendon pathology that we see is tendinosis, which is the degeneration of a tendon's collagen in response to chronic overuse. Tendinitis is inflammation of a tendon, often occurring with acute injury and tendon overload. The term tendinitis is often used interchangeably with tendinosis, but this is not correct as they're different pathologies. Although steroid injections have shown short-term benefits in tendon disorders, it seems that they make things actually worse in the long run. In tennis elbow or lateral epicondylitis, corticosteroids were compared to placebo. The placebo patients did better than the steroid-injected patients at 1 year, and the chance of recurrence of symptoms was over 400% higher in the steroid-injected patients compared to the patients given placebo. This study suggested that steroids actually worsen tennis elbow. Steroids for other tendinopathies also showed inconsistent effects for conditions such as rotator cuff pathology and in the tendons of the legs. In a human study of patients with rotator cuff tendinitis, tendon biopsies after a steroid injection showed irreversible damage, suggesting that steroids may exacerbate the very pathology they're prescribed to treat. What about local anesthetics, which are usually injected along with steroids? Local anesthetics are often injected to decrease pain associated with painful joints and tendons. Some local anesthetics that are commonly used today include lidocaine, bupivacaine, mepivacaine, and ropivacaine. Animal studies have shown that all local anesthetics have toxic effects on cartilage. Local anesthetics have also been shown to be harmful in humans. When patients received large continuous doses of local anesthetics into a joint after a surgery, some patients suffered severe cartilage loss. It's been suggested that local anesthetics, when given into a joint, should be given at very low concentrations. So you might ask, what happens when you mix steroids with local anesthetics? A laboratory study looked into just this question. They compared 3 things. They compared cartilage toxicity of steroids alone to the effects of local anesthetics alone to the effect of a combination of steroid and local anesthetic. It turns out that they all caused the death of cartilage cells. But when the 2 medications were combined, steroid plus local anesthetic, the death of cartilage cells was amplified to a greater degree than when the drugs were used separately. These studies suggest that local anesthetic joint injections should be used with caution. How do steroids affect the rest of the body? As mentioned earlier, steroids can have life-saving effects when a person has a steroid insufficiency. However, giving steroids to someone without an insufficiency has side effects. Even one steroid injection has been shown to have adverse effects. Using steroids can throw off your natural hormone balancing system, also called the hypothalamic pituitary adrenal axis. One study showed that a single steroid injection caused a drop in bone density. Another study showed an increased incidence of spinal fractures, once again after one steroid injection. In diabetic patients, blood glucose levels are usually elevated after a cortisone injection for 2 to 5 days. Even asthma patients on inhaled steroids have shown side effects in the form of tendon ruptures. Cushing's disease, which involves body changes due to excess glucocorticoids, has been reported after injected steroids. Steroids are immunosuppressive, and some studies have suggested an increased rate of infections after joint replacements. They even increase your chance of catching the flu. So with all this information, why are doctors still performing so many steroid injections? Well, steroid injections are still a great treatment for inflammatory conditions such as rheumatoid arthritis, and in some joint problems, steroids may still be the best option for patients. But in cases where it seems that the benefits of steroids are questionable, why are so many doctors still using them? Here are some reasons. When most physicians were trained, steroids were basically all we had. Doctors have been giving steroid injections for decades, and that's just how we do it. Steroid injections are easy to give, and insurance companies pay for steroid injections. In a study out of the United Kingdom in 2015, it was shown that despite evidence that steroid injections delay recovery in tennis elbow, half of elbow specialists were still giving steroid injections to their patients with tennis elbow. What are some alternatives to steroids? If a steroid injection is not the best option for your problem, you now have options. One option for a steroid alternative is viscosupplementation, which is the injection of a thick fluid to lubricate the knee. This can be made from the combs of roosters or made in a lab through bacterial fermentation, and studies have shown this to be effective in the symptoms of knee osteoarthritis. We now have technologies including the innate healing properties of your own cells. These include using platelets from your own blood. These platelets can be concentrated into what's called platelet-rich plasma, or PRP, which contains healing substances such as growth factors. Another healing product derived from the blood is called alpha-2 macroglobulin, or A2M, which has been shown to be helpful in arthritis pain. Cells from your own bone marrow can be used to treat the symptoms of arthritis and joint pathology. Your bone marrow contains many types of cells, including mesenchymal signaling cells, or MSCs. Another treatment that's now available is the use of patient's own adipose tissue or fat. Adipose tissue is also a rich source of mesenchymal signaling cells. So if you're considering a steroid for your spine or joint problem, ask an expert in regenerative medicine what treatment is best for you. Thank you.